One, you can't pass your board exams, in my opinion, without getting some basic science questions right. So it's important for us to highlight that. And the whole reason why we do this course is to give you a competitive advantage going into this examination. So we need to highlight and reflect changes that we think are important in testing. So one of the current trends that's going on in orthopedics is a true paradigm shift. We lived in an age of replacement where you do artificial joints, knees. We're now going into an age of repair where we're talking about biologics, augmenting fracture healing, gene therapy, repair, all kinds of things that now what the board is going to reflect on examinations is that they want their trainees now to at least have a basic understanding of these principles. So that's the reason why we have another lecture on basic science. So if you break it down, what we're actually going to cover today is the Section 4, Chapter 1 in Miller's textbook, Cellular Molecular Biology, Immunology, and Genetics of Orthopedics. And if you actually look at the next slide on your handouts, how much basic science is truly on the examination? A lot. And when you actually break it down, a heck of a lot. My opinion is you can't pass the board exam without getting some basic science questions correct. And if you look at that, 30% of the exam you're going to walk into is combined of basic science knowledge as well as tumor. You can't pass without getting some of these correct. So that's why we have another lecture. So let's go over a little bit of highlighting of what we're going to talk about during today's lecture. If I were just to go about questions now, name me a disorder that has an alteration in a transcription factor. Name me one that has a transcription factor that's missing. Name me another orthopedic disorder that makes a transcription factor from chromosome 11 combining with chromosome 22. Name me on multiple myeloma, the M spike on electrophoresis. What's the immunoglobulin in that? And if we just go down the list, you may not be able to get all those right now off the top of your head. But by the end of the lecture, you'll be able to nail every one of those. Little housekeeping before we begin. If you look at your handouts, go to page 21. On the back there, I've made full-page printouts of things just to help assist preparing for the board exam. One is just on key testable item, which is rank L, and the other ones are just various genetic disorders. One of the key things on this lecture is one of the things that I hated when I sat out there in the audience is that these lectures are not designed just to be regurgitations of Section 4, Chapter 1. It's not designed to do that. My job is to give you a competitive advantage going into that examination and highlight what I think is important, key testable material that's going to show up in your examination. Your exam was written 2 years ago, so it's not important for us to go over the hottest new topic right now. That is not important for the examination. It may be important for your practice down the road, but not right now. Your exam was made 2 years ago, so what I highlight in this lecture is things that I think were important and covered in key hot issues at that time period. So let's go into it. Start with the basics, cellular processes. And this is where we're going to start talking about transcription factors, turning genes on, making proteins. Disorders in orthopedics that are missing these transcription factors. You give medications right now that alter the transcription process. Antibiotics, etc. And we're going to go over those. Simple. DNA goes to RNA in a eukaryotic cell, makes protein. Those proteins then can be on the cell surface, can be excreted, can be maintained in the cell. And we're going to cover disorders that have defects in proteins that are on the cell surface. Proteins that are excreted, you already had that covered in basic science too. Remember how the lecturer talked about how collagen molecules are made? You excrete them from the cell and then assemble them. DNA goes to RNA, goes to protein. Let's highlight this. The reason why I put this slide on. Yeah! That's what I'm talking about. Do it again. All right, yeah. Yeah! So why do I highlight this? And this is actually something very interesting in my training. We had at the University of Pittsburgh 8 residents. 4 residents do a lab rotation. And here's what somebody told me after seeing this video. It was kind of interesting. One of the lab guys that do basic science research looked at it and said, yes, you're going to form a hematoma, and that hematoma has VEGF produced, and you're going to have osteoblastic cells come in and start the fracture healing process. And I'm like, loser. Unbelievable. But you know what? Now that I look back and we're on the other side of the fence presenting a course to give you what's key testable material, that's very important to know. Cellular processes, what happens, and what is important to know on this exam. So the nucleus is the control center. Does everything. And it's very interesting on the nucleus is that we have chromosomes, 23 pairs. If you take one chromosome and just stretch that out, that's 5 centimeters of DNA. So you've got to package that up something fiercely to get that into the nucleus. One of the key testable items we'll go over is how do you actually go about that packaging. Frequently shows up on examinations. So key testable item. DNA is highly packaged and regulated structure in our cell nucleus, the eukaryotic cells. So what? The reason why this is important, they try to fool you all the time on examination by going over different terms, from histones, nucleosomes, chromatin, introns, transcription factors, P53, which is a transcription factor. Let's go over the initial processes on how DNA gets packaged. Remember, if you stretch out one chromosome, that's 5 centimeters. So you have to package it in a highly regulated, organized fashion. Genes. Eukaryotic genes, which is shown on the top, prokaryotic gene, which is the bacterial gene, does not have introns, which are non-coding sequences. Introns, which are in the eukaryotic genes, shown in the diagram on the bottom of the slide, are just those areas of DNA are responsible for packaging and help turning DNA on and off. Eukaryotic cells have a nucleus, has additional DNA called introns, which are non-coding regions. DNA is now packaged in a highly regulated manner. If you start here at the top on DNA, it then goes on beads on a string, which is these negatively charged protein molecules called histones. It then is packaged into nucleosomes. And if you look at your handout, it makes it easier. That next slide shows the way it looks. Beads on a string, which is histones on chromatin, and then that assemble it into nucleosomes. So let's go right into a test question. Have you given a medicine that alters unpackaging of DNA in prokaryotic cells? Well, I'll answer it this way. How do you treat UTIs? How do you treat community-acquired pneumonia? How about diabetic foot? The quinolones. And the answer to that is yes. And if you look at the quinolones, ciprofloxacin, levaquin, tequin, they inhibit DNA gyrase. So right now on packaging DNA, you already do something in your clinical practice that alters the packaging of DNA. Next one. We're going to go now from DNA to making a message. And that's a process called transcription. Transcription starts out by transcription factors binding to unwound DNA. They bind to specific sequences on this unwound DNA called consensus sequences. To show you a better graphic now, example, up here, transcription factors binding to unwound DNA on consensus sequences. We're going to go over diseases that have new transcription factors, altered transcription factors, missing transcription factors. The lecture that was given by Dr. Parsons earlier, where he talked about P53, cell cycle control, it is a transcription factor. Example of an OIT test question. What is the function of a transcription factor? Bind to DNA and influence gene expression. I'll show you the answer there. Now, we've switched to a digital format on your handouts. Now, somebody tell me on the handout, can you at least read this answer pretty clearly? Good. And what this answer will show you a little bit about helicases that unwind DNA, histones that package DNA, which is 3, something that we already covered. Gene transcription. Do you know of any orthopedic conditions have alterations in transcription factors? Well, this, believe it or not, was already covered in the lecture of tumors. That whole class of tumors that we were talking about, small, round, blue cells. Okay? What disease condition has the following characteristics? Homogeneous, small, round cells with lack of prominent nuclei. Which one was that? And you can just look at your handout and see. Ewing sarcoma. Small round cell sarcoma. Age distribution is shown on the bottom of the slide. It's a translocation of chromosome 11 and 22. Well, why is that important? Chromosome 11 now has a DNA binding domain that matches up with chromosome 22, which is a transactivating factor. You're making a novel chimeric transcription factor. This is thought to be involved in the pathogenesis of Ewing sarcoma. So now name me a disorder that has the generation of a new transcription factor. You got it. Ewing sarcoma. Okay, and that's shown on the next slide. A genetic translocation associated with Ewing sarcoma results in decrease in apoptosis, no. Decrease in the activity of a tumor suppressor gene, increased activity angiogenesis factor, expression of a novel chimeric transcription factor. And once again, that's due to a combination of the chromosome 11 DNA binding domain, 22 the transactivation domain. The answer is shown there. The novel chimeric protein binds DNA and acts as a transcription factor. It is believed to have a central role in this transformation. This patient has a deficit in a transcription factor. Let's go over what we see on the radiographs. On your right-hand side, patent fontanelles. On the left side, what do you see there? This person's, wow, they can touch their shoulders in the front, reach all the way across. No clavicles. What's the name of this? Autosomal dominant. Chromosome 6, only in osteoblastic cells. All kinds of test questions. So let's go over which of the following substances essential for bone formation is normally expressed in clinocranial dysplasia, which is the previous slide. Patent fontanelles, absent clavicles. Chromosome 6, only on osteoblastic cells. CBFA1. And the answer is shown below. CBFA1 is a transcription factor that is present only in osteoblastic cells. Let's go over some of the other answers in this question. Carbonic anhydrase 2. What disorder is that? Osteopetrosis. And this is a summary slide. Patient is deficient in a transcription factor, autosomal dominant, chromosome 6, defect in CFBA1, which encodes for a transcription card required for osteoblastic differentiation. So we now covered a new transcription factor and one that's missing in an orthopedic disorder. We've already went over this question. Do you do stuff in clinical practice to alter gene expression and transcription? The answer is yes. What are some other DNA level alterations in orthopedics? And one of the things don't forget is your fluoroscopy. Everything we do in the operating room. The energy that's generated on the production of X-rays can now cause DNA level alterations that can cause cancer, genetic effects in a stochastic model. And there's two effects on radiation. One deterministic, which can be redness on the skin. You need a certain dose to do that. And one that's stochastic, which is not dose dependent. You can get a cancer with exposure to any level, and that's something they found out from Nagasaki and Hiroshima. That response now of cancer termination did not depend on dose dependency. The dose is cumulative, so you can have heritable changes just from the fluoroscopy. Tumor suppressor genes. The definition, they encode proteins that restrict proliferation of cells. Let's go over a couple of good examples of tumor suppressor genes in orthopedics. How about neurofibromatosis? Chromosome 17, neurofibrillin. Not on your handout? Go ahead and write it down. Neurofibromatosis, chromosome 17, neurofibrillin. It's a tumor suppressor gene. Osteosarcoma, one of the ones that was covered previous lectures. Examples include retinoblastoma gene, chromosome 13. Osteosarcomas in these patients can be spontaneous, carry mutations or deletions of this gene. P53, which is transcription factors, have a variety of mutations in this gene. And one of the things that was highlighted in your previous lectures is what percent of sporadic osteocomas have these mutations. In the retinoblastoma gene, 60 to 75% have an abnormality in the RB1 gene or do not produce a functional protein. Also, significant number, 20 to 65%, have P53, which is transcription factor mutations. This patient has the most common single gene disorder in humans. What's this right here? Cafe au lait spot. We talked about neurofibromatosis. Is that a smooth border or a sharp border? Smooth. Which one has a sharp border? McCune-Albright. We'll cover that. Okay, this patient has the most common single gene disorder in humans. Neurofibromatosis, autosomal dominant, neurofibrillin gene, chromosome 17. Let's go over something that didn't show up in your handout. What extra chromosomal element can replicate and be transferred independently of the host chromosome? It's from an OITE question. Plasmid. We know it's not a transcription factor. A promoter is part of the DNA molecule. Bonus material. One of the reasons why I highlight this, I think this is always a key testable item. One of the things that we'll highlight later on in the lecture is whenever you have disorders that involve structural changes, a lot of times those are autosomal dominant. This hitchhiker's thumb is what? Dystrophic dysplasia. It's due to a defect on chromosome 5 of a sulfur transfer protein, but it's autosomal recessive, and that's why I think it sticks out of the bunch. You have a structural abnormality. These are called twisted dwarf, which is the derivative of dystrophic, means twisted. They have scoliosis, etc. The reason why I highlight this, remember, we're talking now of DNA level alterations. Chromosome 5, sulfur transfer protein. What type of dwarf has this? Dystrophic dysplasia. Previous OIT question. Autosomal recessive, mutation of chromosome 5 gene encoding a sulfur transfer protein. Hitchhiker's thumb. Additional material. This I actually saw in a test question. I couldn't believe it, so I went back and looked it up. This patient has a mutation of the LMX1B gene. It doesn't matter to me that you need to know that gene. That's not important. What you see there on the slide is first off, on the lower right-hand quarter, they're missing a patella. On the upper, they're missing nails. And the way this disorder has it, it goes from your thumb down to the small finger is the most prominent nail defects. So the thumb will be the most involved. It's nail patella syndrome, chromosome 9. Iliac horns. Nail patella syndrome. And once again, one of the things that I found out when my job is here to highlight what I think is at least a key testable item. And I couldn't believe that this showed up, but as I really review a lot of test questions, a lot of times you'll find out they test on minutia, not things that we see in everyday practice. And so part of the job here is to give you a competitive advantage just to highlight some of the things that you may want to review on your own. Do I necessarily think this is going to show up? No. But I think it's important to know this is a defect in a gene. We're talking about DNA right now. The LMXB1 gene regulates transcription and limb patterning, and there's also a defect in kidney formation in this disorder. Genomic imprinting. That's this disorder. This is a 7-year-old. In genomic imprinting, I saw on a test question. And what does that mean? In genomic imprinting, you can have a deletion of a segment of a chromosome, either from the maternal side or the paternal side, and it results in 2 different disorders. On this, Prader-Willi syndrome, this patient has hypotonia, hypogonadism, obesity, which is hyperphagia, hypopigmentation, short stature, juvenile onset scoliosis, high percent. Genomic imprinting, it's a deletion of chromosome 15 segment of paternal origin. You delete the same segment of DNA now from maternal origin, you have Angelman syndrome. That's why it's a key testable item. It's called genomic imprinting. This is just one of those brute force memorization things. Name a disorder and a germline defect in GS alpha protein. It's McCune-Albright syndrome. Don't forget that McCune-Albright syndrome includes polyostotic fibrous dysplasia, cafe au lait spots, precocious puberty, hyperfunction of multiple endocrine glands. And when you look at this, you got to say, does this really show up on a test question? And the answer is absolutely. Take a look at what you're already tested on in old OITEs. 10-year-old female, wheelchair, multiple cafe au lait spots, painless bowing deformities of both lower extremities. Figure 58 shows the radiograph right femur. Patients should also be evaluated from which of the following conditions? Well, look back at the previous slide. What are the other things associated with acute albright? You go down the list. Malignant degeneration, endocrinopathy. Well, there you go. Multiple dysfunction of endocrine glands. One of the things I mentioned also on my slides, you see in the lower right-hand corner, if you ever want to go back, and this includes the lectures tomorrow, etc., if you ever want to go back and find out where I got information from, I try to reference every slide that has a picture. Another test question. 10-year-old boy, painful left hip, result of fall while playing baseball. Based on radiographic findings, other abnormalities that are most likely to be present include, once again, McKeown-Albright syndrome, skin pigmentation, and endocrine abnormalities. I don't know why they like this one, but this one frequently shows up, worth knowing. Don't forget skin lesions, neurofibromatosis, chromosome 17, tumor suppressor gene, neurofibrillin, smooth edge, we already highlighted that on the previous slide, fibrodysplasia, coast of Maine, ragged edge. So if they just show you a picture, you'll now at least be able to, on cafe au lait spots, tell the difference. This is one of those ones where I read it and just say, I got to spot them a few questions on my exam. Okay? Spondyloepiphyseal dysplasia, congenital and tartar, precocious arthrosarcopathy, and Stickler syndrome are caused by a mutation in the gene coding for Alex. I don't give a darn for 200. Type 2 collagen. So here's what we covered so far. We're going to go now. We talked about DNA making RNA. We talked about disorders at DNA level. We're now going to start going into translation. So let's go over a gene transcription summary. DNA going to RNA. Ewing sarcoma, we now know that it makes a novel chimeric transcription factor from binding now chromosome 11, DNA binding domain, to chromosome 22, transactivation domain. CBFA1 is missing transcription factor in clinocranial dysplasia. We saw the missing clavicles, patent fontanelles. Quinolone, something you do in everyday practice, alter transcription by inhibiting DNA gyrase. That's levoquin, tequin, ciprofloxacin. Bonus summary, chromosome 5 now, if you want to write this stuff down. We'll go over the chromosomes that we've already covered in the first part of the lecture. Chromosome 5, dystrophic dysplasia, hitchhiker's thumb. Key testable material is it's autosomal recessive. Chromosome 6, clinocranial dysplasia. Remember, only in osteoblastic cells is this CBFA1, autosomal dominant. Chromosome 9, Neil patella syndrome, autosomal dominant. Chromosome 15, genomic imprinting. You take the same section out of chromosome 15 from paternal, you get Prader-Willi syndrome. From maternal, you get Engelmann's. Key testable material. Chromosome 17, tumor suppressor gene, neurofibrillin, neurofibromatosis, autosomal dominant. Cafe au lait spots, smooth border. Does everybody have that down? And the reason why I added this is very simply, is just so that now you have a quick list on the chromosomes we've already covered. Translation. You've already covered, believe it or not, a lot about translation in the previous lectures. You covered about warfarin effects. Well, that's a post-translational effect. We'll go over that. You do something every day on every open fracture that's grade 2 or above to inhibit translation of proteins. It's called gentamicin. We'll go over that. So translation and translational disorders in orthopedics. Translation now is a process of taking this message and making proteins. And those proteins can either stay in the cell, be on the cell surface, like a cell surface receptor protein, and we'll go over orthopedic disorder in that, or it can be secreted. Have you done anything during your training to alter translation of a protein? And the answer is absolutely. Let's go over that then. OITE question. Antibiotic action of aminoglycosides, clindamycin, chloramphenicol, erythromycin, and tetracycline is cell wall permeability? No. Inhibition of cell wall synthesis? Which one's that? Aminoglycosides. I mean the penicillins. inhibition of protein synthesis. That's it. So let's discuss the mechanism and action of each one of these. Rifampin inhibits RNA synthesis. Levaquin is also in that group. Aminoglycosides inhibit protein synthesis. Tetracycline, clindamycin, and macrolides. Test question. Cephalosporin. Effective antibiotic agents because of their action on what aspect of bacterial metabolism? Well, it's not protein synthesis. It's generation of the cell wall. In a quick summary of antibiotic, please refer to Table 144, Miller's Review, for a quick summary of antibiotic actions. And we've already covered a lot. Quinolones inhibit DNA gyrase. Beta-lactams bind to the surface cell membrane. Aminoglycosides inhibit protein synthesis. Rifampin inhibits RNA synthesis in bacteria. And here's a summary. After translation, proteins can be modified and transported to correct locations. We already covered some of that. Covered it in the collagen lecture where the proteins are secreted. We're going to cover here a fibroblast growth receptor defect. Name a disease with a defect in a cell surface protein. It's point deletion, chromosome 4. It results in a protein now that's always on and results in short stature. Has anybody got it? It's autosomal dominant. Achondroplasia. Autosomal defect, fibroblast growth factor receptor 3, results in it's a point mutation that now results in a receptor, and this is actually a question I saw, I couldn't believe it, a receptor that's always on, called constitutively active. So you may want to write that down. This receptor now, because this point mutation, is always on. Let's highlight what this defect, point mutation defect in chromosome 4 causes. Well, now, on the slide, on the left-hand side of the side, you see now the foramen magnum is shortened and constricted. Scoliosis, and then you see rhizomelic shortening. And this one always bothers me, this slide, because I don't understand how you even go to the bathroom with that. Achondroplasia, autosomal defect, fibroblast growth factor, 80% of spontaneous mutation. Constitutively active. You can tell here I missed the question. Parathyroid hormone-related protein and its receptor are implicated in metaphyseal dysplasia. How does warfarin prophylaxis exert its effect? And you decrease the carboxylation of vitamin K-dependent clotting factors, which are shown here. And don't forget on the list also is protein C and protein S are also on that list, vitamin K-dependent. One of the things I also mentioned, did they cover on the previous lecture the reason why you get an increased risk of blood clot after giving warfarin? Did they go over the reason why that happens? Let's go over it real quick then. Protein C and S have the shortest half-life in the vitamin K-dependent clotting factors. So when you give a medication that alters the post-translational modification of these proteins, you'll now shut off those ones first because they have a shorter half-life. That's the reason why when we give Coumadin, you overlap with something else. For example, Lovenox, low molecular weight heparin. You're actually increasing the risk of getting a blood clot in that initial phase. That's why we overlap. Protein C and S, not on this list. Does the process alter translation? This is a key question and frequently missed. Does this process actually alter translation, the making of a protein of the vitamin K-dependent clotting factors? And the answer is no. And let's go why that is. Warfarin prevents DVT by which of the following actions? Competitive inhibition of vitamin K-dependent clotting factors, inhibition of the post-translational modification of vitamin K-dependent clotting factors, reversible or irreversible inhibition, and potentiation of antithrombin 3. This one's frequently missed. Inhibition of the post-translational modification of vitamin K-dependent clotting factors. You need calcium in order to clot. And what ends up happening, you alter the function of an amino acid to where it can bind calcium. The effect of vitamin K prevents that from happening, so you effectively inhibit the post-translational modification of vitamin K-dependent clotting factors. To highlight the answer given, Therefore, warfarin does not competitively inhibit the factors, but rather reduces their active concentration. It is not a competitive inhibition. Keep on going on translational modifications. Little bonus question. What beneficial effect does warfarin provide in the treatment of thromboembolic disease? OIT 2004, question 218. Different way to phrase the same thing we just talked about. You can't do the post-translational modification, which is carboxylation. So you replace normal clotting factors with decarboxylated factors that now can't bind calcium, can't go through your clotting cascade. This disorder has a defect in collagen chain cross-linking, osteogenesis imperfecta. This disorder has a defect in collagen chain hydroxylation, scurvy. Let's go over some other aspects of cellular and molecular biology in orthopedics and some of the key testable items. Orthopedic resident accidentally stuck with a needle from a patient with hepatitis C. Which of the following studies will provide the earliest detection of infection? The presence, essentially, of that molecule, the hepatitis. Immunohistochemistry, polymerase chain reaction, ELISA, northern blot, and western blot. And the bottom line is this is PCR, polymerase chain reaction. Can detect DNA. You amplify small segments of DNA, so very simply, you can now amplify and detect the hepatitis C virus. Answer is shown below. I'll give you a little time to look over that answer. Okay? This is what I consider. Now, this is part of our role in this course is to give you what I think is a key testable item. Don't forget, your exam was written 2 years ago. So the stuff that's really hot right now doesn't apply. It's not going to be tested. Things that we now look, and this is what I consider one of the key testable items that can show up on your examination. For many years, scientists suspected that osteoclast development and bone resorption are under the control of signals elaborated by osteoblasts. Recent identification of rank ligand is shown to be the molecule responsible for this action. Binding of rank L by which of the following molecules will prevent its action, thus prevent bone resorption? Well, before, my attitude would have been just to spot on this question. And I got to be honest, this is worth knowing because I think this is a key testable item. And so let's go over it. The answer is osteoprogerin. Let's go over why that is the answer. The key molecules are involved in osteoclast development and bone remodeling. Rank L. Rank L is on osteoblast. Write that down. It's on the osteoblast. Rank is on the osteoclast. OPG is now produced by osteoblast. And then one of the things I did to help out this, I'm a very visual learner. I like pictures. So I made pictures now to show you each one of these steps in osteoclast activation. Let's start with the osteoblast. Osteoblast has a receptor for rank L. It's expressed after exposure to calcitrophic factors like vitamin D3. So on the osteoblast, you have now expression of the rank L ligand. Next phase of the process. Rank L binding to rank expressed on progenitors, the osteoclast progenitors, activates a signal transduction cascade that leads to osteoclast differentiation in the presence of a survival factor. So on the osteoclast is this rank. Binds to rank L, and then you now make a mature osteoclast in the presence of a survival factor. Remember, the whole process here is to get calcium into your system. So calciotropic factor, vitamin D3, now exposed to the osteoblast. The osteoblast produces rank L. Rank L now binds to rank on the osteoclast precursors, goes down and makes a mature osteoclast that now can pour calcium into your system. Now we got all this revved up. How do you shut it down? There's got to be some way to turn off the process. And that's now the last part. OPG, osteoprogerin. The osteoblast produces OPG. OPG is produced by osteoblasts, acts as a decoy receptor for rank L, and inhibits osteoclast genesis and osteoclast activation by binding to rank. Okay? So the osteoblast is also responsible for revving up the process and shutting it down. So let's go back over the test question. In your handout, the page 21 that I told you there's some expanded figures, this is one of those handouts. To highlight now, you have an osteoblastic cell. You now expose it to calciotrophic factors. It produces this rank L. This rank L now in the osteoclast precursor can bind to rank, tell it to become a mature osteoclast, and put calcium out in the system, okay? Way to shut down the system, remember, osteoblast produces osteoprogerin. Does that make a heck of a lot more sense now? Key testable material. It's actually more complex than this, and I look at this and say, who cares? So let's go back over the test question again. Rank, recent identification of rank ligand shows that the molecule responsible for this action, rank L, binding of rank L, but which of the following molecules will prevent its action, thus prevent bone resorption? Well, we know it now. You've got to shut down the system somehow, and that's prosteoprogerin. Right here's the answer. And one of the things that I really, I'm glad Mark's back here now. One of the things that was amazing when I sat out there in the audience, I think how much money I spent on this course, and he always said that test becomes easier once you know the answers to the questions. And I sat there saying, thank you, Captain Obvious. And when I look at this now, that's part of our role, though, is to make it easier. You look at this question, it doesn't even have a fear factor going into it. So let's take a little quick stretch, and then we'll start the next ones. I'll leave this one up here. This is added. We'll take like a minute or two. Come on back. All right, let's somebody stick their head out in the hallway and tell them to come on and back in. We'll go over the next section of the lecture. Next section we're going to deal with is actually in the same section, Section 4, Chapter 1 of the new review textbook, Immunology and Genetics of Orthopedics. And this is something I think is actually very important. Remember, my thought on giving these lectures is this is not supposed to be a regurgitation of the material in the chapter. It's supposed to highlight what I feel are key testable items to give you a competitive advantage going into the examination. So some of the things you'll be able to answer after coming out, think back now to pediatric rotation. You're on pediatrics and they say that the myelodysplastic kid had type 1 hypersensitivity reaction to latex. What immunoglobulin is responsible for that? What immunoglobulin is responsible for hemophilia, the factor inhibitor, the hemophilia, where you can't do elective procedures? The M-spike, electrophoresis, which immunoglobulin is that? Rheumatoid factor. In rheumatoid arthritis, which 17% of the time presents in the foot as the first place. RF is which type of immunoglobulin? Okay? Multiple myeloma. Multiple myeloma has places where you have bone resorption. Is that due to the B cells or not? Or did the B cells secrete something that caused bone resorption? So we're going to go over those type of things now in this immunology lecture. Just as a quick summary, nonspecific immune response is inflammatory reaction. Histamine release, which I see a lot of people here, allergies in Colorado. Vasodilation, phagocytic cells, enhancement of response by complement, which is 25 proteins. And then you have a specific immune response, which is T lymphocytes produce cytokines, and it can be antibody mediated in addition. Discuss the following immunoglobulins. Type 1 hypersensitivity reaction, you'll get after this. IgM, you'll know which disorders in orthopedics have that. IgG, involved in part of the M spike and electrophoresis. Mucosal surfaces, IgA. IgM, rheumatoid factor, largest, it's fetal. IgG, involved in infection, most common. IgD acts as a receptor. IgE, allergy. For example, the type 1 hypersensitivity reaction in myodysplastic patients to latex because of multiple procedures and examinations in the past. Immunology questions about diseases we commonly see in orthopedics. Name this disease. Okay? If I were to tell you the osteoarthritis shown on the hip here is concentric or non-concentric, which would you choose for? Well, concentric. Pretty concentric all the way across the acetabulum. Whenever I see this picture, I already automatically think of some kind of immunological mediated arthritis destruction, an inflammatory arthritis. And whenever you see this picture, one of the knee-jerk things you got to do on your examination is get a C-spine film. Why? Because C1, C2 is a synovial joint, can form pannus, and look what happens in this disorder. You can now very simply put a patient under anesthesia with rheumatoid arthritis, cause now a fatal incident. Okay? Don't forget the other joints are involved also. So once again, this is the immunology section. Diffuse uniform and narrowing of joint space, severe periarticular osteoporosis, and why is it involved the entire joint? Well, you have these inflammatory mediators out there like IL-1, tumor necrosis factor, etc. You cause now a uniform destruction of the joint. This is not wear and tear arthritis on the superior portion of your acetabulum. This is now a diffuse uniform narrowing. Lack of osteophyte formation, subchondral sclerosis. What are the cellular mediators in this destruction? It's the mononuclear cells. 7%, I think, well, 17% of rheumatoid arthritis actually present in the foot, not in the hand. 43-year-old, 6-month history of pain swelling in the forefoot. Which test is most likely could confirm the diagnosis? And you see here the joint erosions. Erosive changes, metatarsal heads, typical of rheumatoid arthritis. Rheumatoid factor is positive in 80%. So they answered question rheumatoid factor. Let's go down to a question in immunology. What type of immunoglobulin is rheumatoid factor? IgM. Name this disease. They won't ask you this on the board exam. They'll present a patient that's African American that has a low platelet count and anemia. Okay? And they ask you, what kind of examination are you going to get? Are you going to get a bone scan? Or are you going to get a skeletal survey? Skeletal survey. Why is that? Well, it's osteoclasts that are activated. You're putting these punch-out lesions. It's not going to show up on bone scan. Okay? So name this disease. Multiple myeloma. Neoplastic proliferation of a single line of plasma cells, B cells. Sudden onset of bone pain, weakness, fatigue, bleeding, herpes zoster, twice as common in African Americans. Myeloma is a lytic process. True or false question. Bony destruction in myeloma is due to plasma B cells. True or false? False. Why is that? Well, the bony destruction in myeloma, all bony destruction, is due to what? Osteoclast. Well, why does it happen in multiple myeloma? Well, because these B cells now secrete an osteoclast activating factor. This is why you have a negative bone scan, because you're not forming bone in this disorder. That's why you do a skeletal survey. M spike on serum electrophoresis in a patient with myeloma is comprised of what immunoglobulins? IgG and IgA. The bench-stone proteinuria, the small chains, shown here. These are the ones that the patients pee out. Monoclonal light chains appear in the urine. It's called Bence-Jones proteinuria. Why is it monoclonal? Because you have a single proliferation of B cells. You produce one antibody. Name this disease. So let's see what we see. We see arthritis. We see erosion of subchondral bone. We now see on the scan interarticular blood. Hemophilia, periarticular osteoporosis, irregularity of subchondral bone, erosion of subchondral bone, and interarticular blood. Why are we bringing up hemophilia in this lecture? Because hemophilia inhibitors what class of immune globulin? It's IgG, and one of the frequent questions that are asked on the board is the presence of this IgG antibody, the inhibitor factor. Do not forget that the presence of an inhibitor that represents an IgG antibody to clotting factor protein is a relative contraindication to any elective surgical procedure. Inhibitor can develop at any time and is present in 5 to 25% of patients. Let's go over a summary. Now in the back portion of your handout, the expanded section I have a big handout on this, immunoglobulins. Rheumatoid factor, IgM. Hemophilia inhibitor, IgG. M-spike, IgG, IgA. Type 1 hypersensitivity myelodysplastic patient, IgE. Let's go over some of the questions that I've seen on OIT examination. Component of frozen allograft bone has the least amount of immunogenicity. Which one? And the way I break down these questions, I first say, well, what's already in your body? Okay, and then I look at that and say, well, that didn't help me out too much. Then I say, what's mineral versus a protein? And then I look there, bone marrow cells, proteoglycans, hydroxyapatite. There you go. I'll leave that up there for just a little bit. Okay, let's go over general genetic principles. Once again, these lectures are not supposed to be regurgitation of the chapter. If you think we're going to do Punnett squares here, forget it. We ain't doing that. One of the key things now on your handouts, I have the expanded portions for the slides of the various disorders: autosomal recessive, autosomal dominant, X-linked, X-linked recessive, X-linked dominant disorder. I have those in expanded format. But if you look at the Miller's textbook, page 95, table 140 is excellent. Page 95, table 1-40. Autosomal dominant disorders produce structural defects. Name some. Well, we already covered some. Achondroplasia, fibroblast growth factor receptor 3 had a defect. Chromosome 4, point mutation, constitutive active, always on. Marfans, chromosome 15, fibrillin. We covered chromosome 17, neurofibrillin, neurofibromatosis. And this just gives you a list. Malignant hyperthermia, you treat with what? Dantrolene. Why is it important? Because it's autosomal dominant. That's why you ask family history. Do you have any contraindication to anesthesia, and did your family have any problems? They love this one on examination. Autosomal recessive disorders produce, many times, biochemical and enzymatic defects. That is the whole reason why I highlighted this on the top of the list. You've got to think of ones that don't necessarily go with the mix. So you look here, diastrophic dysplasia, sulfur transport protein. Remember the hitchhiker's thumb, diastrophic dysplasia, twisted dwarf, chromosome 5, sulfur transport protein. It's autosomal recessive, even though that patient has true structural abnormalities. So I always think in terms of test questions, which ones don't fit in the mix? And for some odd reason, that becomes a key testable item. Here's some other ones. X-linked recessive disorders. You got to know this one. There's only one in the class. Know it. Love it. X-linked dominant disorder. Hypophosphatemic rickets. I couldn't tell you if it came in my door. Autosomal dominant disorders. Key testable items. Always think structural. Let's go over some test questions. Patient with achondroplasia who seeks genetic counseling is told that there's a defect in the gene encoded for which following proteins? Well, we covered that. Fibroblast growth factor receptor 3. I've highlighted now on your handout the other disorders. Type 2 collagen is shown there. Type 10 shown. COMP shown. Once again, point mutation, chromosome 4, causes this defect, achondroplasia, fibroblast growth factor receptor. It's in the failure of the cartilaginous proliferative zone of physis. Don't forget kyphosis. Fuse if it's greater than 60 degrees. And this is a key testable item shown here on your right-hand side. Decrease interpeduncular distance. Spinal stenosis in this disorder. Okay, decrease interpeduncular distance. Failure of enchondral bone formation. I've highlighted there and underlined spinal stenosis. Champagne pelvis. I always think of it like a ping pong paddle if I'm looking at it directly. Name 2 autosomal dominant disorders that have a defect in comp. One of those rote memorization things. From chromosome 19, pseudoachondroplasia and MED, multiple epiphyseal dysplasia. This patient was normal at birth but fell behind. Has a defect in comp, pseudoachondroplasia. What have I seen on a test question? I actually saw this and it kind of blew my mind. What is this? This is a picture of inclusion bodies. Inclusion bodies of comp in the rough endoplasmic reticulum of the growth plate chondrocytes. Patient with spondyloepiphyseal dysplasia, type 2 collagen defects should be screened for what eye problems? Retinal detachment and myopia. And one of the things always when you're studying, always try to group things together. Like, so let's talk about eye disorders real quick. Lens dislocations in two disorders, homocystinuria and Marfan syndrome. The easiest way I think about that, Marfan's because the person's tall, like Abe Lincoln, superior lens dislocation. Homocystinuria, inferior. I always try to group, when I studied for these examinations, things in one big class. Retinal detachment, I now know it's SED. Dysplasia associated with coxavera and retinal detachment. Well, we got that now. SED, autosomal dominant, type 2 collagen defect. And once again, I highlight where I've had these slides made from, so you can go back and reference if you need to. Real quick list. What are defects for the following autosomal genetic diseases? Achondroplasia, we've already covered. Nice dysplasia, type 2 collagen. Type 10 collagen, metaphyseal dysplasia. Osteopetrosis, autosomal dominant, osteoclast dysfunction. Marfan syndrome, we already covered that, superior lens dislocation. Fibrillin defect on chromosome 15. Malignant hyperthermia, treat with dantrolene. Always get the family history on anesthesia. And once again, the classification. I told you the way I study, and that's why I have this as a slide. Which is associated with superior lens dislocation? I gave you the easiest way I think about it. That person's tall, like an Abe Lincoln. Superior lens dislocation. Homocystinuria would be inferior lens dislocation. Patient has a single most common gene disorder in humans. Well, we already covered this. Chromosome 17, defect in neurofibrillin, tumor suppressor gene. Smooth border, cafe au lait spots. Test question. 1-year-old infant, subtroch femur fracture. Examination, the infant falls below the 5th percentile for height and weight, although the head circumference is normal. Radiographs show no discernible medullary canal of the femur. What is the most likely diagnosis? Well, it's kind of easy. I checked off. Obviously, I got this one right when I took the test. Osteopetrosis. How do you treat it? What do you do? Bone marrow transplant. Albert Schlossberg, 1904, was when it was originally described. Patients with hereditary motor and sensory neuropathy type 1 and increased risk for which are falling hip abnormalities. They love these type of questions where they show you another joint, Nash disorder in a joint above it. They're at risk for dysplasia. Autosomal dominant, that's why I covered it in this lecture. Demyelinating disorder, perineal muscle weakness. Fascioloscapulohumeral dystrophy. This question I highlight actually in my anatomy lecture because it's a frequent item on scapular winging. They love this one. It's autosomal dominant. Which procedure now is improving the function? Scapulothoracic arthrodesis. Whole reason once again why it's in this section. Small region chromosome 4, it's autosomal dominant. Key testable items now on autosomal recessive. Always, if you have to guess, one of the things also of this course, if you have to guess, at least have something known cold. Autosomal recessive, if you even think about it, it's most likely going to be a structural or enzymatic defect. I've already highlighted the one that stands out of the mix. Dystrophic dysplasia. What is deficient in homocystinuria? Autosomal recessive. Cystathione B synthetase. Which way does the lens dislocate? We already said inferior. Marfan's superior. Disorder that results from a defect in homogenistic acid oxidase. This is the one that can pee in a cup that turns black as you put it on the windowsill. That'd be a great college party trick. Ochronosis. Autosomal recessive. Let me tell you the way I look at this chart. First off, who cares? Okay, let's get that out of the way. Secondly, they do test on minutia on this examination. So here's the way I look at this chart. I go down the list and ask, which one is different than all the others? Right here you go. And guess what? That shows up on examinations. Which one is different than all the others? Autosomal recessive, blah, 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 blah. X-linked recessive. Well, guess what? I'm going to know Hunter's. Mucopolysaccharidosis. That's the way I use these charts that are in the book. I think the charts that are in the Miller's Review book are excellent. But this is the way I use the charts. Which one falls out of the mix? Because now if I get a test question on mucopolysaccharidosis, I at least now know it's autosomal recessive. I could have guessed that anyways. And now I've got to go through my hand, well, what's Hunter's? Well, that's what we highlight next. Mucopolysaccharidosis is autosomal recessive, has normal intelligence. Let's just break it down. That's more Quitos, normal intelligence. Associated with mental retardation, urinary excretion of dermatan or heparan sulfate. Hunter's, Hurler's, Sanfilippo's. Sex-linked recessive, ding, 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 ding. One that's different than all the others in the group. Hunter's. This syndrome has a deficiency of beta-glucocerebrosidase. Gaucher's. They don't test you on this. Here's what they test you on in this one. This is a great one. They try to fool you with leg calf perthes. You now have a 12-year-old, splenomegaly. You have minor flaccid deformity there of the femurs. You have the following picture. And they tell you that AVN of the hip is now the most frequent complication. But they show you a picture of bilateral AVN of the hips. If you think back now in your pediatric lectures, how many times did bilateral AVN of the hips happen in leg calf perthes? About 15%. Not in this one. You got bilateral. So you already now, once again, I told you how I study. I think about what falls away from the others. I now know AVN of hips, and they're doing a question. I've already narrowed it down to a couple things. Leg calf perthes versus this, Gaucher's disease. And if they show me a picture bilateral, I already know which direction I'm heading. Gaucher's disease, autosomal recessive. Abnormal deposition of cerebrosides in the reticular endothelial system of the spleen, liver, and bone marrow. Diffuse osteoporosis. Most common complication is osteonecrosis of the femoral head. AVN of bilateral hips. Leg calf perthes, only 15% of that is bilateral. I think it's always important to reinforce things that were already covered, and that way I'm doing you a service now going in an exam. There's some things you know cold. Once again, you got this. Hitchhiker's thumb, autosomal recessive, dystrophic disorder, dysplasia, chromosome 5, sulfur transfer protein. You have kyphosis. That's the whole reason why it's a twisted dwarf. Does her dysplasia have a risk of scoliosis? This was an actual picture. Look at that. Does it? Twisted dwarf? Heck yeah. X-linked. What disorder involves a defect in the short arm of chromosome 10? X chromosome, sorry. Dystrophin gene. Duchenne's muscular dystrophy. Is this a recessive or dominant? We already said there was only one dominant. So let's go back over the list again. It's recessive. X-linked recessive disorder. Which muscles are affected first? Hip extensors. In the same class, X-linked recessive is this, hemophilia. We already talked about immunoglobulin, IgG. So let's provide a summary of where we've been and what we covered. What are the defects for the following genetic diseases? Achondroplasia, FGF receptor 3, proliferative zone of the physis is involved, diastrophic dwarfism, sulfur transfer protein, chromosome 5, Nice dysplasia, type 2 collagen, metaphyseal dysplasia, 10, rickets, osteogenesis imperfecta, and we'll just go down the list. And this is covered excellent on Table 1-41, pages 96 to 99. 1-46, page 96 to 99. It's the most complete chart I've ever seen. It's unbelievable. Well, I hope I give you a good overview here of what I think is important to know. Hope it gives you a competitive advantage going into examination. I wish you the best.